Question 1. A 63-year-old male presents to the emergency department with acute chest pain is exhaustion segment elevation in Leeds PV. The patient reports that the pain started while he was shoveling snow and is associated with nausea and diaphoresis. He is also a smoker with a history of hypertension. Given this presentation, which of the following is the most appropriate immediate management? A. Administer nitroglycerin and aspirin and prepare for thrombolytic therapy. B. Steroids and administer opioids for pain control. C. Perform a focused history and physical examination, then proceed with cardiac catheterization. D. Administer anticoagulation therapy and wait for the cardiology consult to determine the next step. Answer A. Administer nitroglycerin and aspirin and prepare for thrombolytic therapy. Explanation. This patient's symptoms and findings are highly suggestive of an acute STEMI and segment elevation myocardial infarction. Immediate management should involve the administration of aspirin to inhibit platelet aggregation and nitroglycerin to alleviate pain and reduce myocardial oxygen demand. Thrombolytic therapy may be considered easy. A cutaneous coronary intervention is not immediately available. The administration of opioids and fluid management, option B, is not the first-line treatment in this setting. Cardiac catheterization, option C, is important but not the immediate first step in an emergency setting. Anticoagulation, option D, is part of the therapy but does not take precedence over thrombolytics or PCI in the acute phase of STEMI management. Question 2. Mrs. Thompson, a 74-year-old woman with a history of COPD and hypertension, is brought to the emergency department with severe shortness of breath and a history of worsening cough. Her oxygen saturation is 88% on room air, and she is experiencing increased wheezing. Which of the following interventions is most appropriate for her condition? A. Administer intravenous antibiotics and prepare for intubation. B. Initiate non-invasive positive pressure ventilation (BiPAP) and administer nebulized bronchodilators. C. Begin aggressive fluid resuscitation and monitor urine output. D. Administer steroids and bronchodilators intravenously, then prepare for mechanical ventilation. Answer. B. Initiate non-invasive positive pressure ventilation (BiPAP) and administer nebulized bronchodilators. Explanation. Mrs. Thompson's presentation is consistent with an acute exacerbation of COPD, likely triggered by an infection or environmental irritant. The most appropriate initial management includes non-invasive positive pressure ventilation (BiPAP) to improve oxygenation and reduce the work of breathing. Nebulized bronchodilators albuterol are crucial to open the airways. Intravenous antibiotics are not indicated without clear evidence of bacterial infection, option A. Aggressive fluid resuscitation, option C, is typically not indicated in COPD exacerbations unless there is evidence of hypovolemia or shock. Steroids and bronchodilators intravenously may be used later, but mechanical ventilation should not be the first step unless non-invasive support fails, option D. Question 3, scenario-based. Mr. Rodriguez, a 34-year-old male, is involved in a motor vehicle accident where he was a restrained passenger. He presents to the emergency department with complaints of severe neck pain, but he is neurologically intact and has no signs of traumatic brain injury. The physical exam reveals tenderness over the cervical spine, but no obvious deformities or neurological deficits. What is the most appropriate next step in the management of Mr. Rodriguez? A. Obtain a cervical spine X-ray and, if normal, remove the collar and allow the patient to mobilize. B. Order Bacnia the cervical spine to rule out any fractures and initiate cervical spine immobilization until results are available. C. Immediately transfer the patient to a neurosurgical unit for further management. D. Discharge the patient with instructions to follow up with orthopedic surgery for a cervical spine consultation. Answer. B. Order a K of the cervical spine to rule out any fractures and initiate cervical spine immobilization until results are available. Explanation. In trauma cases with potential cervical spine injury, especially when there is significant neck pain and the patient is at risk for fractures, cervical spine immobilization is critical until further evaluation can rule out a serious injury. A key is the most accurate method for assessing cervical spine in patients with trauma, as it can detect fractures or dislocations that might not be apparent on X-rays. Removing the collar prematurely, option A, without appropriate imaging poses a risk of worsening a potential injury. Transferring the patient to a neurosurgical unit, option C, is unnecessary unless there are neurological deficits or other indications for immediate surgical intervention. Discharging the patient, option D, inappropriate in the acute setting without proper imaging to rule out A cervical spine fracture. Question 4. A 50-year-old female with a history of type 2 diabetes and chronic hypertension presents to the emergency department with sudden onset left-sided weakness and difficulty speaking. Her blood pressure is elevated at 109 to 100 Hg and her heart rate is 88 EM. A non-contrast CT scan of the head reveals no acute hemorrhage and her National Institutes of Health stroke scales. 9. What is the next best step in her management? A. Administer thrombolytic therapy immediately. B. Begin blood pressure lowering therapy and prepare for possible thrombolytic therapy. C. Transfer to a stroke unit for observation and initiate anticoagulation therapy. D. Administer aspirin and monitor for improvement. Answer. B. Begin blood pressure lowering therapy and prepare for possible thrombolytic therapy. Explanation. The patient is presenting with an acute ischemic stroke given her clinical presentation and CT findings. However, the elevated blood pressure in stroke patients, especially those in the acute phase, requires cautious management. Rapid lowering of blood pressure to avoid worsening ischemia is indicated, but it should be done slowly to avoid complications. Thrombolytic therapy can be considered if the patient meets criteria for intravenous thrombolysis, e.g., symptom onset within 4.5 hours, no contraindications. Anticoagulation therapy, option C, is not indicated in the acute phase of ischemic stroke, and aspirin, option D, is part of secondary prevention but not acute management. Immediate administration of RPA, option A, without careful assessment of blood pressure and exclusion of hemorrhage is not appropriate. Question 5. A 25-year-old male presents to the emergency department with complaints of sudden onset chest pain and shortness of breath after a traumatic fall. He has a history of asthma and reports mild wheezing on exertion. On examination, he is tachycardic and his blood pressure is 110/7 mmHg. Auscultation reveals decreased breath sounds on the left side, and a chest X-ray shows a large left-sided pneumothorax. What is the next step in his management? A. Immediate needle decompression followed by chest tube insertion. B. Start high-flow oxygen and monitor closely for respiratory distress. C. Perform a thoracentesis to evacuate the pneumothorax. D. Intubate the patient and provide mechanical ventilation. Answer. A. Immediate needle decompression followed by chest tube insertion. Explanation. This patient has a traumatic pneumothorax and his decreased breath sounds and tachycardia suggest significant respiratory compromise. Immediate needle decompression should be performed if tension pneumothorax is suspected, as indicated by signs of respiratory distress, followed by chest tube insertion to prevent recurrence of the pneumothorax. High flow option B can help in some cases, but it does not treat the underlying cause of the pneumothorax. Thoracentesis option C is used for pleural effusions, not for pneumothorax management. Intubation and mechanical ventilation, option D, are not necessary unless the patient is unable to maintain an adequate airway or is in severe respiratory failure. Question 6. A 38-year-old male is brought to the emergency department after being struck in the chest during a rugby game. He reports severe central chest pain and difficulty breathing. Physical examination reveals a distended neck vein, hypotension, and muffled heart sounds. His X shows electrical alternans. What is the most likely diagnosis and what is the next best step in management? A. Cardiac tamponade. Initiate pericardiocentesis. B. Pulmonary contusion. Provide mechanical ventilation. C. Tension pneumothorax or perform needle decompression. D. Aortic dissection. Administer antihypertensives and prepare for surgery. Answer. A. Cardiac tamponade. Initiate pericardiocentesis. Explanation. This patient presents with classic signs of cardiac tamponade, including hypotension, distended neck veins, muffled heart sounds, Beck's triad, and electrical alternans on X, suggesting cardiac movement in fluid-filled pericardial space. Cardiac tamponade should be treated immediately with pericardiocentesis to relieve pressure on the heart. Pulmonary option B would typically present with respiratory distress, but the presence of muffled heart sounds suggests tamponade, not lung injury. Tension pneumothorax, option C, would cause unilateral chest pain and tracheal deviation, which this patient does not exhibit. Aortic dissection, option D, presents with sharp, ripping chest pain, but is less likely given the findings of muffled heart sounds and electrical alternans. Question 7. A 5-year-old child is brought to the emergency department by his parents who report that he has had a fever, cough, and difficulty breathing for the past 24 hours. On examination, the child appears lethargic and his oxygen saturation is 88% on room air. Chest X-ray shows a consolidation in the right lower lobe, blood cultures ascent, and a diagnosis of community-acquired pneumonia (CAP) is suspected. What is the first-line treatment for this condition in a child of this age? A. Amoxicillin, B. Ceftriaxone, C. Azithromycin, D. Vancomycin. Answer A. Amoxicillin. Explanation: community-acquired pneumonia in children is often caused by Streptococcus pneumoniae or other bacterial pathogens. The first-line treatment for pediatric CAP typically involves amoxicillin, which covers Streptococcus pneumoniae. Ceftriaxone, option B, is an appropriate alternative for more severe cases but is not typically first-line for uncomplicated CAP. Azithromycin, option C, is used for suspected Mycoplasma pneumoniae or other atypical bacteria, but the classic presentation with consolidation suggests a bacterial pneumonia that is most likely due to Streptococcus pneumoniae. Vancomycin, option D, is reserved for suspected methicillin-resistant Staphylococcus aureus MRA infections, which are less common in this age group unless there is a history of complicated or Question 8. A 29-year-old female presents with abdominal pain, fever, and a history of nausea and vomiting for 48 hours. She has a history of gallstones and previous episodes of biliary colic. Physical examination reveals right upper quadrant tenderness and a positive Murphy sign. Labs show an elevated white blood cell count. What is the most likely diagnosis and what is the next appropriate management step? A. Acute pancreatitis. Initiate supportive care and fluid resuscitation. B. Acute cholecystitis. Initiate Rominair antibiotics and prepare for surgery. C. Hepatitis. Initiate antiviral therapy. D. Peptic ulcer disease. Initiate proton pump inhibitors. And H. Pylori treatment. Answer: B. Acute cholecystitis. Initiate Rominair antibiotics and prepare for surgery. Explanation: this patient presents with symptoms and signs of acute cholecystitis, a common complication of gallstones as evidenced by right upper quadrant tenderness, fever, and a positive Murphy sign. The elevated white blood cell count further supports an inflammatory or infectious process. The most appropriate management for acute cholecystitis involves initiating Rominair antibiotics to cover common pathogens, e.g. E. coli, and preparing for surgical intervention, typically cholecystectomy. Acute pancreatitis, option A, would present with epigastric pain and elevated pancreatic enzymes. Hepatitis, option C, typically presents with jaundice and elevated liver enzymes, not right upper quadrant tenderness. Peptic ulcer disease, option D, presents with dyspepsia, not the signs of acute cholecystitis. Question 9. A 70-year-old male with a history of hypertension and smoking presents with severe sudden onset back pain, which he describes as the worst pain of his life. He also reports dizziness and lightheadedness. Physical examination reveals the EV100-8G and an absent left femoral pulse. What is the most likely diagnosis and what is the most appropriate next step in management? A. Acute myocardial infarction. Initiate aspirin and nitroglycerin. B. Abdominal aortic aneurysm rupture. Prepare for emergency surgery. C. Acute pancreatitis. Initiate Romanuids and pain management. D. Thoracic aortic dissection. Perform a angiogram. Answer: B. Abdominal aortic aneurysm rupture. Prepare for emergency surgery. Explanation: this patient's sudden onset, severe back pain, along with hypotension and absent femoral pulse, is highly suggestive of an abdominal aortic aneurysm (AO) rupture. AO rupture is a life-threatening emergency that requires immediate surgical intervention. The patient's history of hypertension and smoking increases his risk for acute myocardial infarction, option A, typically presents with chest pain, not back pain, and would not explain the absent femoral pulse. Acute pancreatitis, option C, usually presents with epigastric pain and gastrointestinal symptoms, not back pain or absent pulses. The aortic dissection, option D, presents with chest pain and may cause unequal pulses, but the location of the pain and absent femoral pulse make E-rupture more likely. Question 10. A 72-year-old male presents to the emergency department with confusion, fever, and urinary incontinence. He has a history of benign prostatic hyperplasia (BH) and is on tamsulosin. Physical examination reveals a fever of 38.7 dec, increased heart rate, and mild tenderness in the lower abdomen. Urinalysis shows cloudy urine with positive leukocyte esterase and nitrites. What is the likely diagnosis and what is the appropriate treatment? A. Acute pyelonephritis. Initiate oral antibiotics. B. Acute cystitis. Initiate antibiotics and increase fluid intake. C. Acute prostatitis. Initiate intravenous antibiotics and supportive care. D. Urinary tract infection. Monitor and provide symptomatic treatment. Answer: C. Acute prostatitis. Initiate intravenous antibiotics and supportive care. Explanation: this patient's symptoms of fever, confusion, urinary incontinence, and lower abdominal tenderness, along with the urinalysis findings, suggest acute prostatitis, which is commonly seen in older men with BEH. Prostatitis is often associated with systemic signs like fever and confusion, especially in elderly individuals. Treatment with intravenous antibiotics initially due to the severity and potential for sepsis. Acute pyelonephritis, option A, would involve flank pain and may present with fever, but the presence of lower abdominal pain and confusion makes prostatitis more likely. Acute cystitis, option B, would present with dysuria, frequency, and urgency, but not typically with fever and confusion. Urinary tract infections, option D, but in the presence of prostatitis, they require more aggressive treatment. Question 11. A 40-year-old female with a history of chronic alcohol use presents with confusion, tremors, and a history of recent heavy drinking. She is diaphoretic and has a heart rate of 110 bpm, blood pressure of 159 mmHg, and a temperature of 37.8 Dick. The physician suspects alcohol withdrawal delirium. What is the most appropriate next step in management? A. Administer dose of lorazepam and monitor for improvement. B. Provide fluids and administer thiamine with no immediate need for benzodiazepines. C. Begin intravenous fluids and thiamine, along with haloperidol for agitation. D. Administer loading dose of lorazepam, followed by gradual tapering. Answer A. Administer dose of lorazepam and monitor for improvement. Explanation: alcohol withdrawal delirium, also known as delirium tremens, is a severe form of alcohol withdrawal, often presenting with agitation, confusion, tremors, tachycardia, and fever. The most appropriate next step is the administration of a benzodiazepine, e.g. lorazepam, to reduce withdrawal symptoms and prevent progression to more severe complications. 5. Option B is important for preventing Werner-Korsakoff syndrome in patients with alcohol use disorder, but should be given along with other medications, not instead of benzodiazepines. Haloperidol, option C, is an antipsychotic used for agitation, but it is not the first-line treatment for alcohol withdrawal delirium. Gradual tapering, option D, is used in chronic alcohol use disorder, but acute withdrawal delirium requires prompt medication. Question 12. A 54-year-old male with a history of coronary artery disease presents with shortness of breath, fatigue, and lower extremity edema. His blood pressure is 128 mmHg, heart rate is 88 bpm, and he has bilateral pitting edema. A chest X-ray reveals cardiomegaly and pulmonary congestion. What is the most likely diagnosis, and what is the next best step in management? A. Acute myocardial infarction. Administer aspirin and nitroglycerin. B. Heart failure with reduced ejection fraction. Initiate ACE inhibitors and diuretics. C. Pulmonary embolism. Initiate anticoagulation therapy. D. Chronic obstructive pulmonary disease. Provide bronchodilators. Answer: B. Heart failure with reduced ejection fraction. Initiate ACE inhibitors and diuretics. Explanation: this patient's symptoms of shortness of breath, fatigue, lower extremity edema, and findings of cardiomegaly and pulmonary congestion on chest X-ray suggest heart failure with reduced ejection fraction, H4F. The most appropriate treatment includes ACE inhibitors to reduce afterload and diuretics to manage fluid overload. Myocardial infarction, option A, would present with chest pain and is unlikely without other ischemic signs. Pulmonary embolism, option C, would typically present with sudden onset of shortness of breath and pruritic chest pain, not the findings of heart failure. COPT, option D, would cause chronic respiratory symptoms and would not present with edema or cardiomegaly. Question 13. A 30-year-old female presents with fatigue, weight gain, and cold intolerance for the past few months. Her physical examination shows dry skin, a slow heart rate of 50 bpm, and a palpable goiter. Blood tests reveal a IVL of 15 mmol and Freed of 0.6 What is the most likely diagnosis and what is the first-line treatment? A. Hyperthyroidism. Initiate methimazole. B. Hyperthyroidism. Initiate levothyroxine. C. Hashimoto's thyroiditis. Administer steroids. D. Thyroid cancer. Refer for biopsy and surgery. Answer: B. Hyperthyroidism. Initiate levothyroxine. Explanation: This patient presents with symptoms and laboratory findings suggestive of primary hypothyroidism characterized by high TH and low Freed levels. The most appropriate treatment is the initiation of levothyroxine, a synthetic thyroid hormone. Hypothyroidism, option A, would present with symptoms such as weight loss, heat intolerance, and an elevated heart rate. Hashimoto's thyroiditis, option C, is a common cause of hypothyroidism but does not typically require steroids unless there is inflammation. Thyroid cancer, option D, may present with palpable thyroid mass but is not suggested by the patient's symptoms and lab results. Question 14. A 60-year-old male with a history of atrial fibrillation and stroke presents with acute right-sided weakness and difficulty speaking. On examination, his right arm and leg are weak, and he has expressive aphasia. AEK of the head reveals a large ischemic infarct in the left middle cerebral artery distribution. What is the next best step in his management? A. Administer intravenous thrombolytics if within the therapeutic window. B. Begin anticoagulation therapy to prevent further strokes. C. Initiate aspirin therapy for acute stroke prevention. D. Perform a mechanical thrombectomy for large vessel occlusion. Answer A. Administer intravenous thrombolytics if within the therapeutic window. Explanation. This patient is presenting with an acute ischemic stroke, and intravenous thrombolytic therapy RPA is the best option if the patient is within the therapeutic window, typically within 4.5 hours of symptom onset. The decision to administer RPA is based on the time of symptom onset and the absence of contraindications such as surgery or bleeding. Anticoagulation, option B, is not recommended in the acute phase of ischemic stroke due to the risk of bleeding. Aspirin, option C, is often used for secondary stroke prevention but is not used in the acute management of ischemic stroke. Mechanical thrombectomy, option D, is reserved for patients with large vessel occlusions, especially if the time window allows. Question 15. A 45-year-old male presents with sudden onset sharp chest pain radiating to the back associated with difficulty swallowing and hoarseness. He reports a recent history of hypertension and smoking. On physical examination, his blood pressure is 110 mmHg in both arms, and there is a difference in pulse between the upper extremities. A chest X-ray reveals a widened mediastinum. What is the most likely diagnosis and what is the next step in management? A. Acute myocardial infarction. Initiate thrombolytics. B. Aortic dissection. Initiate blood pressure control and prepare for surgery. C. Pulmonary embolism. Administer anticoagulation. D. Esophageal rupture and prepare for surgical repair. Answer B. Aortic dissection. Initiate blood pressure control and prepare for surgery. Explanation. This patient's sudden onset chest pain, radiating to the back, and physical exam findings of hypertension and widened mediastinum on chest X-ray are classic signs of an aortic dissection. The next step in management is controlling blood pressure to reduce stress on the aortic wall and preparing for surgery or endovascular repair, depending on the and location of the dissection. Acute myocardial infarction, option A, is typically associated with chest pain and neck changes, not back pain and widened mediastinum. Pulmonary embolism, option C, may present with chest pain, but is unlikely to cause widened mediastinum. Esophageal rupture, option D, would present with severe chest pain, dysphagia, and subcutaneous emphysema, but not the findings of aortic dissection. Question 16. A 50-year-old male with a history of chronic kidney disease presents with increasing difficulty breathing and swelling in his legs. He has a blood pressure of 106 to 100 mmHg and has gained 4 kilograms in the past week. A chest X-ray shows pulmonary congestion, his creatinine is elevated and urine output is reduced. What is the most appropriate next step in his management? A. Increase fluid intake and monitor kidney function. B. Initiate diuretics and adjust blood pressure medications. C. Start antibiotics for possible pneumonia. D. Administer intravenous fluids to improve renal perfusion. Answer B. Initiate diuretics and adjust blood pressure medications. Explanation. This patient is presenting with signs of volume overload, likely due to fluid retention associated with chronic kidney disease (CKD). The next best step in management is the use of diuretics to reduce fluid overload and control symptoms of pulmonary congestion. Adjusting blood pressure medications is also crucial to prevent further kidney damage. Fluid intake, option A, would exacerbate his symptoms, and antibiotics, option C, are not indicated in the absence of signs of infection. Intravenous fluids, option D, could worsen his volume overload and should not be used unless there is evidence of hypovolemia. Question 17. A 65-year-old female presents with progressive shortness of breath, fatigue, and swelling in her legs for the past several months. She has a history of hypertension and coronary artery disease. On examination, her blood pressure is 138 Hg, heart rate is 72 bpm, and she has bilateral lower extremity edema. A transthoracic echocardiogram shows reduced ejection fraction and left ventricular dilation. What is the most likely diagnosis and what is the next best step in management? A. Heart failure with preserved ejection fraction. Initiate diuretics. B. Heart failure with reduced ejection fraction. Initiate ACE inhibitors and beta blockers. C. Pulmonary hypertension. Initiate sildenafil. D. Coronary artery disease. Proceed with coronary angiography. Answer: B. Heart failure with reduced ejection fraction. Initiate ACE inhibitors and beta blockers. Explanation: is patient presence with symptoms of heart failure and the echocardiogram findings of reduced ejection fraction and left ventricular dilation are consistent with heart failure with reduced ejection fraction, HFrEF. The most appropriate treatment includes ACE inhibitors to reduce afterload and beta blockers to improve cardiac function. Reduce mortality in HFrEF. Heart failure with preserved ejection fraction, option A, is less likely given the reduced ejection fraction. Pulmonary hypertension, option C, would present with different symptoms and signs and is not suggested by the echocardiogram findings. Coronary artery disease, option D, is a risk factor for heart failure, but coronary angiography is not the next step unless there is suspicion of acute coronary syndrome. Question 18. A 48-year-old male presents with hemoptysis and a cough lasting for several weeks. He also reports unintentional weight loss, night sweats, and a history of recent exposure to a known tuberculosis patient. His chest X-ray shows upper lobe consolidation. What is the most likely diagnosis and what is the appropriate next step in management? A. Tuberculosis. Initiate standard anti-tuberculosis regimen and isolation precautions. B. Lung cancer. Refer for biopsy and staging. C. Pneumonia. Initiate antibiotics and observe for improvement. D. Bronchitis. Treat with bronchodilators and corticosteroids. Answer: A. Tuberculosis. Initiate standard anti-tuberculosis regimen and isolation precautions. Explanation: this patient's symptoms of hemoptysis, weight loss, night sweats, and exposure history are highly suggestive of tuberculosis TB. The next step in management is to initiate an anti-tuberculosis regimen including rifampin, isoniazid, pyrazinamide, and ethambutol, and place the patient in airborne isolation to prevent transmission. Lung cancer, option B, is possible but less likely given the exposure history and symptoms. Pneumonia, option C, could present similarly but does not explain the prolonged symptoms or exposure. Bronchitis, option D, would not present with hemoptysis or weight loss and would not require isolation. Question 19. A 68-year-old male with a history of smoking presents with a persistent cough, hemoptysis, and weight loss over the past 2 months. On examination, he has decreased breath sounds and dullness to percussion over the left lung base. The chest X-ray shows a large mass in the left lung with a pleural effusion. What is the most likely diagnosis and what is the next best step in management? A. Pneumonia. Initiate broad-spectrum antibiotics. B. Lung cancer with malignant pleural effusion. Proceed with thoracentesis and biopsy. C. Pulmonary embolism. Initiate anticoagulation therapy. D. Tuberculosis. Begin anti-tuberculosis therapy and isolation precautions. Answer: B. Lung cancer with malignant pleural effusion. Proceed with thoracentesis and biopsy. Explanation: this patient's symptoms of cough, hemoptysis, weight loss, and examination findings of dullness to percussion and a pleural effusion are highly suggestive of lung cancer with a malignant pleural effusion. The next best step in management is to perform a thoracentesis to analyze the pleural fluid, followed by biopsy to confirm the diagnosis. Determine the type of cancer. Pneumonia, option A, could present with a cough but does not explain hemoptysis and weight loss. Pulmonary embolism, option C, would not present with a pleural effusion. Tuberculosis, option D, could present similarly but would not cause a large mass on chest X-ray. Question 20. The 32-year-old female presents with a 6-month history of joint pain, stiffness, and swelling in her hands, wrists, and knees. She also complains of fatigue, morning stiffness lasting for over an hour, and difficulty performing daily tasks. Laboratory tests reveal a positive rheumatoid factor, elevated SO, and positive anti-CP antibodies. What is the most likely diagnosis and what is the first-line treatment? A. Systemic lupus erythematosus. Initiate hydroxychloroquine. B. Rheumatoid arthritis. Initiate methotrexate and NSAIDs. C. Osteoarthritis. Recommend weight loss and physical therapy. D. Gout. Initiate allopurinol and colchicine. Answer: B. Rheumatoid arthritis. Initiate methotrexate and NSAIDs. Explanation: this patient's symptoms of joint pain, stiffness, and swelling, along with the positive rheumatoid factor, elevated ESA, and positive anti-CP antibodies, are highly suggestive of rheumatoid arthritis. The first-line treatment for RA includes methotrexate, which is a disease-modifying anti-rheumatic drug, DMARD, and NSAIDs to manage pain and inflammation. Systemic lupus erythematosus, option A, could cause joint pain, but would have additional systemic symptoms such as a butterfly rash and specific autoimmune markers. Osteoarthritis, option C, presents with joint pain, but typically affects weight-bearing joints and has a different clinical course. Gout, option D, presents with acute, severe pain, usually in the big toe, and is associated with elevated uric acid levels. Question 21. A 60-year-old male with a history of diabetes and hypertension presents with sudden onset severe abdominal pain, nausea, and vomiting. He is diaphoretic and his blood pressure is 90/60 mmHg. On examination, his abdomen is tender and there is guarding in the epigastric region. A ECANI of the abdomen shows a ruptured abdominal aortic aneurysm. What is the next best step in management? A. Administer intravenous fluids and prepare for surgery. B. Initiate broad-spectrum antibiotics and wait for stabilization. C. Perform a laparotomy to repair the rupture. D. Begin blood transfusion and consult for an interventional radiology procedure. Answer: A. Administer intravenous fluids and prepare for surgery. Explanation: this patient is presenting with signs and symptoms of a ruptured abdominal aortic aneurysm, which is a medical emergency. The most important initial step is to administer intravenous fluids to stabilize the patient, followed by preparation for immediate surgical intervention, either open repair or endovascular repair. Antibiotics, option B, and laparotomy, option C, are not indicated as the first step in management. Blood transfusion, option D, is essential but comes after fluid resuscitation to address hypovolemic shock. Surgical repair is the definitive treatment for a ruptured A. Question 22. A 25-year-old female presents with a new onset of double vision and difficulty swallowing, along with weakness in her arms and legs that worsens throughout the day. She has no significant past medical history. On examination, there is ptosis and weakness in her proximal muscles. Her reflexes are normal, and sensory examination is intact. What is the most likely diagnosis, and what is the next step in management? A. Myasthenia gravis. Perform an acetylcholine receptor antibody test. B. Guillain-Barré syndrome. Initiate intravenous immunoglobulin (IVIG) therapy. C. Multiple sclerosis. Order MRI of the brain and spinal cord. D. Amyotrophic lateral sclerosis. Refer for electromyography. Answer: A. Myasthenia gravis. Perform an acetylcholine receptor antibody test. Explanation: this patient's presentation of double vision, difficulty swallowing, proximal muscle weakness, and ptosis that worsens with activity is highly suggestive of myasthenia gravis, an autoimmune disorder that affects the neuromuscular junction. The next step in diagnosis is to perform an acetylcholine receptor antibody test to confirm the diagnosis. Guillain-Barré syndrome, option B, would present with ascending weakness and sensory changes and would require IVIG therapy. Multiple sclerosis, option C, typically presents with episodes of neurological deficits and requires MRI for diagnosis. Amyotrophic lateral sclerosis, option D, is progressive neurodegenerative disease that presents with muscle wasting and weakness but does not typically present with ocular symptoms like ptosis. Question 23. A 45-year-old female presents with a 3-day history of fever, chills, and dysuria. She has no significant past medical history and is not sexually active. Physical examination reveals costovertebral angle tenderness, fever of 39 Nick, and tenderness to palpation over the lower abdomen. Urinalysis shows leukocyte esterase, nitrites, and white blood cells. What is the most likely diagnosis and what? First-line treatment. A. Acute cystitis. Initiate short course of antibiotics. B. Acute pyelonephritis. Start intravenous antibiotics. C. Urinary tract infection. Initiate antibiotics and recommend fluids. D. Bladder cancer. Refer for cystoscopy and biopsy. Answer: B. Acute pyelonephritis. Start intravenous antibiotics. Explanation: This patient's presentation of fever, chills, dysuria, costovertebral angle tenderness, and abnormal urinalysis findings suggest acute pyelonephritis, bacterial infection of the kidney. The first-line treatment involves starting intravenous antibiotics to treat the infection and prevent complications. Acute cystitis option A would typically present with urinary tract symptoms, but not with systemic symptoms like fever or costovertebral angle tenderness. Urinary tract infection option C could also be the diagnosis, but the presence of fever and renal tenderness indicates pyelonephritis. Bladder cancer option D would not present with fever, chills, or abnormal urinalysis findings. Question 24. A 50-year-old male with a history of alcohol use disorder presents with altered mental status, asterixis, and jaundice. His laboratory results show an elevated ammonia level, and his liver function tests are markedly abnormal. What is the most likely diagnosis and what is the most appropriate treatment? A. Hepatic encephalopathy. Initiate lactulose and rifaximin. B. Acute pancreatitis. Initiate fluid resuscitation and pain management. C. Cirrhosis. Begin diuretics and beta blockers. D. Alcoholic hepatitis. Administer corticosteroids and alcohol cessation. Answer A. Hepatic encephalopathy. Initiate lactulose and rifaximin. Explanation. This patient is presenting with hepatic encephalopathy, a complication of liver failure commonly seen in patients with cirrhosis or liver disease. Symptoms include altered mental status, asterixis, and jaundice. The most appropriate treatment is the use of lactulose, which helps reduce ammonia levels in the body, and rifaximin, an antibiotic that reduces production of ammonia by gut bacteria. Acute pancreatitis option B would present with abdominal pain and elevated pancreatic enzymes, not altered mental status and jaundice. Cirrhosis option C could explain the symptoms, but the patient's altered mental status suggests hepatic encephalopathy specifically. Alcoholic hepatitis option D might also be considered, but the primary treatment would involve addressing hepatic encephalopathy. Question 25. A 72-year-old male presents with confusion, restlessness, and tremors. He has a history of Parkinson's disease and is on levodopa therapy. His wife reports that he has had difficulty managing his symptoms recently and has been more fatigued. His blood pressure is 106 Hg and his heart rate is 72 bpm. What is the most likely cause of his symptoms and what is the next best step in management? A. Parkinson's disease progression. Adjust levodopa dosage. B. Medication-induced dyskinesia. Reduce levodopa dosage. C. Neuroleptic malignant syndrome. Discontinue levodopa. D. Infection-related delirium. Initiate antibiotics. Answer A. Parkinson's disease progression. Adjust levodopa dosage. Explanation. This patient's symptoms of confusion, restlessness, and tremors, along with his history of Parkinson's disease, suggest disease progression. Parkinson's disease can lead to worsening motor symptoms, which can present with altered mental status and other neurological signs. The next best step is to adjust the levodopa dosage to improve motor control. Medication in dyskinesia option B typically presents with abnormal involuntary movements, not confusion or restlessness, and would require reducing the levodopa dosage. Neuroleptic malignant syndrome option C is rare, life-threatening reaction to antipsychotic medications and would present with hypothermia, muscle rigidity, and altered mental status, but this patient is not on such medications. Infection-related delirium option D is possible cause confusion, but the patient's Parkinson's disease progression is more likely cause in this context, and there is no indication of an infection. Question 26. A 40-year-old male with a history of hypertension presents with acute chest pain that started suddenly while he was at rest. The pain is described as sharp and radiates to his back. He is sweating profusely and is in significant distress. On examination, his blood pressure is 100 to 100 Hg and his pulse is 100 TEM. The chest X-ray shows a widened mediastinum. What is the most likely diagnosis and what is the next step in management? A. Acute myocardial infarction. Administer aspirin and thrombolytics. B. Pulmonary embolism. Initiate anticoagulation therapy. C. Aortic dissection. Obtain an EKG of the chest with contrast. D. Pericarditis. Initiate anti-inflammatory therapy. Answer. C. Aortic dissection. Obtain an EKG of the chest with contrast. Explanation. This patient's acute chest pain, sharp in nature and radiating to the back, along with widened mediastinum on chest X-ray and history of hypertension, is highly suggestive of an aortic dissection. The next step in management is to obtain CT scan of the chest with contrast to confirm the diagnosis. Acute myocardial infarction, option A, could present chest pain, but the characteristics of the pain and the chest X-ray findings suggest aortic dissection. Pulmonary embolism, option B, could also present with chest pain and tachycardia, but it would typically present with shortness of breath and is less likely to cause widened mediastinum. Pericarditis, option D, would present with different pain pattern and does not cause widened mediastinum. Question 27. A 68-year-old female presents with a 2-month history of worsening fatigue, unintentional weight loss, and night sweats. On examination, she has generalized lymphadenopathy. Her complete blood count (CBC) shows anemia, leukocytosis, and thrombocytosis. A lymph node biopsy reveals Reed-Sternberg cells. What is the most likely diagnosis, and what is the next step in management? A. Chronic lymphocytic leukemia and start chemotherapy. B. Hodgkin lymphoma, stage the disease and initiate chemotherapy or radiation. C. Non-Hodgkin lymphoma, begin rituximab therapy. D. Tuberculosis, initiate anti-tuberculosis therapy. Answer B. Hodgkin lymphoma, stage the disease and initiate chemotherapy or radiation. Explanation: this patient's presentation of fatigue, weight loss, night sweats, and generalized lymphadenopathy, along with the presence of Reed-Sternberg cells on biopsy, is highly suggestive of Hodgkin lymphoma. The next step in management is to stage the disease with imaging studies such as PET-CT scans and then initiate chemotherapy or radiation. Depending on the stage, chronic lymphocytic leukemia, option A, would present with different findings on the CBC and is not associated with Reed-Sternberg cells. Non-Hodgkin lymphoma, option C, could present with similar symptoms but does not have Reed-Sternberg cells. Tuberculosis, option D, could cause generalized lymphadenopathy but would not explain the Reed-Sternberg cells. Question 28. A 55-year-old male with a history of chronic alcohol use presents with jaundice, ascites, and encephalopathy. His laboratory tests show elevated liver enzymes and a prolonged prothrombin time. On examination, he has spider angiomata and polymerythema. What is the most likely diagnosis, and what is the next step in management? A. Hepatitis B, start antiviral therapy. B. Cirrhosis, initiate diuretics and beta blockers. C. Acute alcoholic hepatitis, administer corticosteroids. D. Non-alcoholic fatty liver disease, initiate weight loss and lifestyle changes. Answer B. Cirrhosis, initiate diuretics and beta blockers. Explanation: this patient's symptoms of jaundice, ascites, encephalopathy, and examination findings of spider angiomata and polymerythema suggest cirrhosis likely due to chronic alcohol use. The next step in management includes starting diuretics, such as spironolactone, to manage ascites and beta blockers, such as propranolol, to prevent variceal bleeding. Hepatitis, option A, could lead to cirrhosis but is less likely to cause the symptoms in this patient without known history of hepatitis B infection. Acute alcoholic hepatitis, option C, would present more acutely with liver dysfunction but would not explain the chronic symptoms. Non-alcoholic fatty liver disease, option D, is more common in patients with obesity or metabolic syndrome and would not explain the severe liver dysfunction seen here. Question 29. A 70-year-old male with a history of diabetes and hypertension presents with a 3-day history of worsening shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea. On examination, he has bilateral lower extremity edema, rails on auscultation, and a displaced apical impulse. What is the most likely diagnosis, and what is the first step in management? A. Acute myocardial infarction, administer aspirin and nitroglycerin. B. Congestive heart failure, initiate diuretics and ACE inhibitors. C. Chronic obstructive pulmonary disease, initiate bronchodilators. D. Pulmonary embolism, start anticoagulation therapy. Answer B. Congestive heart failure, initiate diuretics and ACE inhibitors. Explanation: this patient's symptoms of worsening shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and physical examination findings of bilateral edema and rails suggest congestive heart failure, CHF. The first step in management includes initiating diuretics, such as furosemide, to reduce fluid overload, and ACE inhibitors, such as enalapril, improve cardiac function. Acute myocardial infarction, option A, could present with shortness of breath, but the absence of chest pain and the presence of rails points to CHF. Chronic obstructive pulmonary disease, option C, could cause shortness of breath but would not cause orthopnea or paroxysmal nocturnal dyspnea. Pulmonary embolism, option D, could cause shortness of breath but would also present with pleuritic chest pain and is unlikely to cause the findings seen on examination. Question 30. A 60-year-old female presents with a history of progressive difficulty swallowing, regurgitation of undigested food, and a sensation of food sticking in her chest. She has lost 10 pounds in the past month. A barium swallow reveals a bird beak appearance at the lower esophagus. What is the most likely diagnosis and what is the next step in management? HLA refer for esophageal manometry and consider pneumatic dilation or surgery. B. Gastroesophageal reflux disease. Initiate proton pump inhibitors. C. Esophageal cancer. Refer for endoscopy and biopsy. D. Esophagitis. Initiate antifungal therapy. Answer A. Achalasia refer for esophageal manometry and consider pneumatic dilation or surgery. Explanation. This patient's symptoms of progressive dysphagia, regurgitation, and weight loss, along with the bird beak appearance on barium swallow, are characteristic of achalasia. The next step in management is to refer for esophageal manometry, which is the gold standard for diagnosis, followed by consideration of pneumatic dilation or surgery. Treatment. Gastroesophageal reflux disease, option B, could cause dysphagia but would not typically present with bird beak appearance on imaging. Esophageal cancer, option C, could cause dysphagia but would typically present with more progressive weight loss and history of smoking or alcohol use. Esophagitis, option D, could cause dysphagia but would not typically present with bird beak appearance on imaging.